Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Acadia Pharmaceuticals, Inc.
Hello, I'm Dr. David Lieberman, child neurologist, instructor of neurology at Harvard Medical School. Welcome to this program titled Rett Syndrome Year in Review, What We Learned in 2025 and Beyond. Joining me today is Dr. Tim Fama, who's a child neurologist at Gillette Children's and at Noran Neurology Clinic in St. Paul, Minnesota. Welcome, Tim.
Thank you, Dr. Lieben. Glad to be here.
Today we'll be discussing developments in Rett management that occurred during 2025 and the beginning of 2026. So, Tim, can we start with the caregiver burden in Rett?
Happy to. I'm broadening the borders of this talk just a bit to talk about a 2024 paper because this makes a beautiful highlight in interviewing 756 caregivers that even on some of the scales that we follow in Rett, something may be mild severity, but the burden to the caregiver is disproportionate. So even sleep difficulties, seizures, pain, and behavioral abnormalities may be minor, but they can have significant impact on a disease that is usually chronic and mildly progressive, even in the longer term. To continue on the theme of caregiver burden, Dr. Lieberman, can you tell us more about the Rett syndrome caregiver assessment of symptom severity?
Sure. So let me just give a little background here. So up to this point, we've been using the Rett Syndrome Behavior Questionnaire as one of the caregiver outcome measures in Rett, but it was really more of a diagnostic tool than a tool to assess change. And there's been things like aberrant behavior checklist and anxiety, depression, and mood scales that are non-specific for a number of neurodevelopmental disorders, and they only have a few items that would be pertinent necessarily for Rett syndrome. So this study utilized data from the Rett Natural History Study. It looked at something called the Interval History Form that was developed in 2014. It looked at 40 items and basically whittled down to first 6 core domains: hand skills, communication, sitting, standing, walking, behaviors, and mood and abnormal behaviors, and as well as co-occurring conditions. And uh, there's a range of skills that have to be caught on the spectrum of Rett syndrome patients. Then they can range from very mild to very severe. So they used a factor analysis to reduce a large number of these observed correlated variables into a smaller, manageable set of unobserved latent variables. So the 4-factor model had the best fit. It covered movement, communication, behavior, and Rett-specific symptoms. And the movement section here is Explore, where you can see the listing of different movements that were categorized and put on a Likert scale from mild to more severe. So higher scores would have more severity. And there's also listed here is some of the communication measures that were included in this. And these are a lot more than what was previously included in the Rett Syndrome Behavior Questionnaire. So looking across, we can see strong face validity and conversion validity. Here they're showing that measures on this RCAS, which are higher, correlate with a higher degree of severity as seen by the mutation type. When you kind of look at the range from milder to more severe, it correlates with the test scores on these assessment tools. So this is a promising measure. Here they showed it affecting the Rett motor behavior assessment, where higher scores also show greater severity in the clinical severity score. Same showing that these all correlate. And I think this RCAS will probably be used in more clinical trials moving forward. And I think it's going to turn out to be a more reliable instrument. There still needs to be work on it about test, retest, and inter-rater reliability, which have not yet been established. Next, let's talk about the latest on treatments. Tim, what's the latest clinical trial results from the LOTUS study on trofinetide, And for our listeners, that's the only FDA-approved therapy for Rett syndrome.
Thanks again, Dr. Lieberman. So yeah, also happy to speak to this as we transition from what is caregiver burden and how do we assess caregiver burden. We can begin to transition to how do we actually help treat the disease. And this is the first FDA-approved treatment for Rett syndrome and trofinetide. And I think both you and I were PIs in the quest to better understand the impact of what trofinetide could have for these families. This study is unique and very helpful because this is the longer real world observational study of 227 caregivers. And we know that when this drug was released, there was significant issues with diarrhea. What would the compliance be like? What would the longer term be like? Because drug trials are often somewhat shorter. But what this study showed essentially is that with slow titration, we saw that 71 to 90% of caregivers reported behavioral improvements. And the diarrhea was mostly mild with that slower titration, and it seemed to lessen over time. Real world benefits are consistent with controlled trial findings, and that there's continued efficacy and tolerability that does increase over time with the right management prospectively.
Tim, what about the results of the interview study with caregivers of participants exiting open label trofinetide trials?
Yeah, thanks, Dr. Lieberman. I think in 33 caregivers of participants that were exiting open label trials, they saw improvements, even in older children, of attention, engagement, eye tracking, eye gaze, hand use. Not all, but a significant amount in a disease that is progressive. And typically we don't see gains like this. And we saw improvements in younger children with Daffodil, who had been part of the Daffodil study with new words, hand use, and eye contact. And 97% of caregivers were satisfied or very satisfied. As another provider, Dr. Lieberman, who's seen all these Rett patients over the longer term, what are your thoughts about this study and what you're seeing in your clinic?
Oh, no, it's a great question. I mean, I think importantly is the diarrhea is much less of a burden if, as you said, the medication is titrated, and then you add things like fiber supplements that can help manage it over time, which allows higher doses to be given for these individuals. It's great to see the families feeling that there's been impact in their child's lives from these interventions.
It's a lot of work to do it, and so it's good to see the benefit of it. But
Tim, what about the results from the expert consensus on real world use of trofinetide?
thanks again. So yeah, in regard to where does trofinetide have a role or a place in managing Rett syndrome, and I think it is the first line and really only treatment we have specifically for Rett at this time. I think it's important to get a baseline for these kids. So before we put them on treatment, we do assessments, we do counseling. And initiating trofinetide is a skill as well in regard to we typically have recommended dosing by the FDA, but there is some custom titration and also diarrhea and bowel management we need to do. And so as we do that, if the children are tolerating this, then we also have to assess the benefits and also the tolerability, which comes along with the skill in titrating the med, in managing the bowel and GI issues that are side effects, and also knowing when to discontinue or pause it, because not all children do tolerate it, but many can be retrialed, and we often can meet success with finding the right dose, the right titration, and hopefully the benefits that we hope to see in the studies with better hand use, better presence, and again, developmental skills that typically wouldn't come back or not be seen at these ages without trofinetide.
That's terrific. It's really promising for future use.
So next on treatments, Dr. Lieberman, can you tell us about the ketamine study, as there's other studies in the pipes as well?
Sure, Tim. This is a trial that was started years ago before the pandemic, but the data was just compiled and published recently. So this was based on some preclinical studies and anecdotes that were in the Rett population, where patients who received ketamine either for anesthetic purposes or sometimes to help with seizures showed remarkable improvements in the few days after receiving dosing. And so there was a trial done um, uh, to evaluate the short-term safety and efficacy of oral ketamine, where the patients got 5 days of treatment, where they would get either oral ketamine or placebo. Then there would be a 9-day washout, and then they would get the opposite treatment. And this was for girls aged 6 to 12 who had a diagnosis of classic Rett. And 4 doses were proposed in the trial originally, but we only had availability for the the lowest 2 doses before the pandemic broke out and recruitment became more difficult. So there were clinician ratings and parent ratings, as well as physiological monitoring with EEG that would be used to distinguish if the target was engaged. There would be changes in brain physiology with ketamine, as you would expect. There was no clinical benefit. Ketamine didn't show any statistically significant difference from placebo in the outcome measures that were proposed here, but it was safe and well tolerated. There was one instance of treatment-related vomiting. And we did see target engagement even at these low doses. The EEG showed that ketamine was active in the brain because there was a higher power frequency, which was noted. The change that was seen in alpha delta ratio, for example, suggests that maybe a longer dosing period might be necessary to see physiological changes. So, unfortunately, the COVID-19 pandemic kind of curtailed this, but there's interest in looking at this at higher doses and maybe now with intranasal ketamine, which has been approved for other disorders like depression.
Lastly, David, can you tell us about the splicing of MECP2 as a potential therapeutic strategy for Rett syndrome?
Sure, Tim. Let me tell you why I was interested in this trial. I'll mention in a bit about the gene therapy trials that are underway, but this is using another approach where we might be in the future using an antisense oligonucleotide which would cause changes in DNA expression. But the feasibility of this approach was demonstrated in these animal model studies. There's two versions of messenger RNA for the MECP2 gene. There's a E1 and E2 isoforms, and they differ whether exon 2 is included. It's included in the E2, but not the E1. So the question is can we make more E1 from the E2 that's uh, already present in the cells? It's less effective overall E2 at baseline, but then it becomes more effective. It becomes E1, and maybe we could do that with a exon 2 skipping mechanism. And then that way, basically, we're increasing endogenous MECP2 and hopefully causing less overexpression. So the authors first did a deletion of exon 2 in the mice to see what the impact would be. Also, an exon 2 skipping morpholino in mice and assessed what its impact on MECP2 protein levels would be. So in the E2 knockout mouse, they found that the E2 mRNA triggered a significant upregulation of the E1 isoform, and the MECP2 protein levels went up by 50 to 60% in cortex and other brain regions. They also looked at behavioral outcomes from in these mice, and the mice moved pretty well. Their motor learning and memory were good. There were some deficits in anxiety in the mice, but the female mice did not show some of those same differences. And they looked at iPSCs derived from a male patient with a mutation, and they said, all right, now if we took that iPSC cell and knocked out E2, what happens? And they saw increase in spike frequency that in the mutant form that then was normalized when you knocked out the E2, and basically the mRNA levels returned to lower levels, and the relative MECP2 protein expression came up like you were hoping for. So it's kind of a rescue of the this G118E mutation. So basically, just to bring it home, they injected morpholinos as well, either into a tissue culture or into the animal, and then harvested the brain tissue and saw a rescue of protein levels from the administration of the morpholino. Lastly, I'll just make a comment about a couple of gene therapy programs that had been in phase 1-2 trials, and now we're both in phase 3 trials. So there's the TSHA 102 that was done both in adults and pediatric patients, where it's an AAV9 is administered intrathecally with a mini MECP2 gene in a self-complementary vector, and that is opposed to the NGN 401 that was done primarily in a pediatric study. Also an AAV9 construct with a full-length MECP2 and a single-strand construct, but in this case, it's administered intraventricularly. And the advent of gene therapy is here now, and we'll see where these trials take us. Tim, what are your thoughts?
My thoughts is at the current time, it's never been more of a hopeful time to try to have some therapies and promising future therapies to offer to the caregivers for these patients suffering from Rett syndrome. It's been a long road to get here, and we've cared for lots of patients over the years where we just try to manage symptoms. And we are beginning to attack some of the root causes and reverse some of the core symptoms and actually see development we just hadn't seen before. So it's a very hopeful time to be in this space and care for individuals with Rett syndrome, especially with the gene therapies on the horizon as well.
That's great. It's definitely a good time to be in the midst of interventional trials and basic research in Rett syndrome. Thank you very much.
Thank you, David, for this great discussion on Rett syndrome as well. I've really enjoyed it and also collaborating with you over the years. And thank you, audience, for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation for this activity. Thank you.